Welcome. Are we connected on Teams? We're good to go. Have we let everybody in? Very good. In which case, I think now is a good time to start, as it's 5 o'clock. So welcome to everybody who's joined us in the room here. Good to see you all, and welcome to everybody who's joined us on Teams. Thanks to the tech staff who have set up this magnificent setup for us. So hopefully you will be able to hear and see us if you're not here. So I'm Matthew Swindells, and I am the chair of the board of the Acute Provider Collaborative, which of course includes Hillingdon Hospital, as well as Chelsea and Westminster, London North West, and Imperial College Hospital. So a few housekeeping items before we start. Firstly, this meeting is recorded and will be posted online. So by attending, you are consenting to this. So please also be aware, if you have your camera on at home, we can see you. Please also be aware that we've muted everybody who's dialed in's microphones, so we can minimise the background noise and you can all hear the presenters. If you require captions dialed in from home, please click the Language and Speech tab on your Teams, and you should find a captions option there. And then at the end, we will have time for some questions at the end of the meeting following the presentations, and we'll try to answer as many as we can in the time available to us, but then any that don't get answered, we will pick up and answer online for you. So please post your questions in the chat function by clicking on the chat button at the top of your screen, or if you are in the room, you could do it in the traditional way by raising your hand. Any questions that we don't manage to answer, the meeting will take away and the relevant executive will pick that up. I'm joined here today by Leslie Watts, recently street-side nurse, leaping out of her car to support someone who come off their motorbike on the A40, so has rushed in just before the meeting as she was seeing them into the back of an ambulance. And not a drug addict. Okay, it hadn't crossed anybody's mind you were a drug addict until you said that, Leslie. We're also joined by the Trust's executive team. I think we have online Carolyn Downs, our Vice Chair. We have several of our non-executive directors have joined us both online and in the room. And we have our lead governor, Ian Bendel, who will be talking to you shortly, as well as Virginia Massaro, our Chief Finance Officer, who will also be talking to you shortly. We will be hearing from some of our staff and partners with some presentations after we've heard from Leslie and Virginia. And we will be sharing with you some of our new developments, particularly around our breast surgery breakthrough, around virtual wards, and around the project to rebuild Hillingdon Hospital. Hillingdon Hospital is part of the North West London Acute Provider Collaborative that was established in 2022. The scale of the opportunity to improve health for the 2.5 million people who live in North West London is huge, and I'm really pleased by the progress that we have made over the last 3 years. In the summer this last year, we published our new North West London Acute Provider Collaborative strategy for the coming 3 years after an extensive engagement with both colleagues and patients across our geographic area. And this sets out our mandate for change and identifies the strengths through which we think that we will be able to help our remarkable staff provide ever-improving care and research for the patients and people that we serve. Over the last year, we have looked at 28 clinical pathways, which are the 28 specialties which are run by all 4 trusts in North West London, and we've had our clinical teams working together to identify what is the best practice and how do we bring that together to make it available to everybody in North West London? Part of our philosophy is firstly to say what's the best that happens in North West London, and how do we make sure everybody gets that? Then say to ourselves, well, what's the best that happens in the NHS, and how do we bring that into North West London? And an example of that has been the progress we've made with our elective orthopaedics centre, which recently received accreditation as an example of best practice from NHS England. It offers state-of-the-art centre of excellence for routine bone and joint surgery with care based on the national guidance for best practice. And so far it's treated more than 3,000 patients, and an average length of stay of less than 2.5 days, a reduction in how long people are staying in hospital by about a day, and has had 96% positive feedback from patients who've gone through there. And we were also congratulated by the patient lobbying groups for the quality of the consultation that went on for that. And in technology, we've been one of the national leaders for the development of the Federated Data Platform, which allows colleagues on wards to track patients as they move through the hospital and ensure that unnecessary delays in their discharge or their treatment are avoided. So over the last 12 months, we've demonstrated the extent to which we can make significant and rapid improvements when we work collectively together. And now, with a new vision and strategy, we look forward with confidence to being able to do more and more for the people of North West London, and continue to build on what is already, I think, the best performing group of hospitals in the NHS, to continue to extend excellence and deal with it where things are not as good as they ought to be, because however good you are, you've never solved everything. So this evening, we're going to start with a short video about the Trust, and then Leslie will talk to us about the achievements and the challenges and the performance from the year that's just finished, 2024 to 25, and a bit of a look ahead. And then we will have a financial review from Virginia, followed by presentations from our from some of our colleagues and staff. So first of all, let me play the video for you, which I think is there.
This is a massive breakthrough. This is really innovative because we're using a purely keyhole technique, which means that when they wake up, they will feel a lot better. They will have a better overall experience, and that is key with cancer surgery.
I'm feeling great.
The icing on the cake for Tanya is that she has just been told she's now cancer-free.
It'd be fair to say that Hillingdon Hospital isn't looking its best. It's not the place you'd expect a government minister to come to, unless, of course, they're about to rebuild this place. And they are.
Really pleased to be here to give my support, the department's support, the government's support to the team here to get on with this now.
Hillingdon was the only London trust to get the go-ahead for a new hospital. They say it will transform healthcare in the area.
Very good. And lots of pictures of Sarah, our chief nurse, turning up, a bit like Zeeling. Wherever something happens, there's a picture of Sarah. So, but let me hand you over now to Leslie. Thank you very much.
Thanks very much, Chair. Evening, everyone, and it's an absolute pleasure and indeed an honour to be here at the first annual meeting at Hillingdon for me, not for all of you, I know. So I want to start off actually I'm going to talk obviously about the progress that we're making at Hillingdon and as Matthew said, some of the challenges that we've got. But I just wanted to just spend a second on what I found when I came here. And what I found was the friendliness of staff and the kindness of staff to patients, the fact that it feels a big part of the community, staffed by much of the community actually, and indeed the aspiration of our clinicians. And you've seen some of that just play out now, and it's really heartwarming to see. I want to pay special tribute actually to the exec team that are here, so particularly Alan, Sarah, Jason's here as well, who are absolutely committed to this organisation, have absolutely supported me over the last few months in a very challenging time. We've got some newcomers to the exec team. We've got Virginia, who you'll hear from later. We've got Peter. We've got Kevin. So we're really trying to build a team for the organisation that actually leads the organisation into the future, and indeed works really well with the other parts of, I'm going to forget, aren't I? Not used to having to do this myself, so I'll have to do better. But that will lead this organisation into the future. But a really big tribute to all the staff that work here, who work incredibly hard. So I wanted to talk a little bit about our journey of improvement. So as you know, the CQC came some time ago, and some of that was on the back of some concerns. But I hope that some of you have seen the CQC report, which absolutely documents some of the progress made here, and is a testament to the seriousness, actually, that was taken in terms of the reflections of the CQC and the response to those. So that's been really, really good. The redevelopment plans, Matthew just nuanced. Big well done to Jason and to the team that have led that work. I mean, one of the reasons that we're going to have a new hospital, you're going to have a new hospital in Hillingdon, is because of the commitment to actually listening to the advice from the centre and responding to that advice that said we are determined to have a new hospital, our community deserves that new hospital, and we now know we're going to get that new hospital. So it's an amazing thing, and you saw Karen on here. This did make me smile a little bit. Our trust was voted the best trust for food. So actually I haven't eaten here very often, but I am now going to give it a go. But it did have the highest rating in the country, so that's something to be incredibly proud of. Thank you. So we need to, of course, to talk about our performance. So our trust, alongside the rest of the NHS, has had its challenges. We know that we had some challenges, particularly around our ED performance. I hope you'll be pleased to hear that we have sustained some improvement on that. We've rethought about how we provide that service and the commitment of staff, not just in our ED department, but throughout the hospital, that has allowed us to realise some of that ambition. The RTT standard, this is the standard which is people who are on a waiting list, how quickly do they get treated? That has been pretty stable in a way during a period of time when many places have deteriorated. And actually, over the last couple of months, again, we've seen an improvement. That we have agreed an improvement trajectory. We're pretty determined that we will finish the year at 60%. It's called our target is 60%. We're pretty sure that we will reach that target. And our cancer treatment standards has improved really phenomenally during this period as well. So again, that's a tribute to all of the clinicians who worked very hard on that. And you saw the comment on Pharmacy First, which is a program that looks at patients that are coming into us who actually could go to pharmacy. That has been accepted as NHS England as the template for the future, and so that project will be rolled out across the country. So something to be very, very proud of here. So you saw a little bit as well about, one of the great tributes that we should pay to staff, particularly clinicians actually, is during the period of time when every day you're treating patients, how do you think of doing that better? And you saw the work on the breast surgery. There is a lot of work on our digital. And I think that there is, we started a series of deep dives in the organisation. And that allows us, the exec team, to look at every service in detail. And we look at the quality of care, the operational performance, how we look after our people, and indeed how we do that within the resources. Every single specialty that we've seen so far has been so proud to come and tell us about the great things that they're doing, and that is an absolute tribute to all of them. But does say something. It takes effort when you're working very hard to take a step back and still take time to think we could do better. So really, really proud of that. We've got a new research and innovation strategy which has been published, and that is being embedded into our routine care. We've got an AI solution to the analysis, the looking at chest x-rays in particular. So, how do we test, use clinicians' time when we really need to use it, but actually for routine mundane things, how do we use technology to do that much more quickly and release that time? There are other people who are probably better able to describe some of this stuff to you. But there's a thing called Copilot, which some of you will know about, which actually is a digital assistant, again, to our clinicians to release time to allow them to deliver the clinical and technical care in the best way that they can. One of the things that we've thought a lot about, actually, particularly Sarah, who you saw in many of those, she's photogenic, but actually a lot of this work, sorry Sarah, but you've got to lighten the mood sometimes. Actually a really important part of, if staff feel like they're looked after, then actually it makes it easier for them, the environment easier for them to look after patients, particularly actually when we're still waiting for the new build and all of the disruption that brings. And so thinking about recognition of staff, thinking about their well-being, talking about it openly, ensuring that we share some very precious moments, recognising the things that they've done really well, be it the ward accreditations, be it the Hillingdon Hearts. All of those things are really important and has really been embraced by the organisation and is something, again, that bonds the organisation together. The quality of care that we deliver is probably the most important thing that we do. So thinking about not just what we do, but how we do it, ensuring that actually we keep our patients safe, ensuring that we learn from sometimes when we do get things wrong, making sure that we learn from that. So alongside some of the rest of the country, we've implemented calls for concern. So that was about Martha's Rule. So if patients, particularly their relatives, want a second opinion, we've got a whole process in how we do that. The patient safety incident response framework. So this is how we record incidents, areas of concern in a systematic way, and how we examine those areas of concern and how we embed the learning that comes out of anything that we get wrong. That's been embedded both here, but across the rest of the collaborative as well. And the really interesting bit about that, of course, is it allows us to compare and to learn from each other as well, something that's really, really important. We thought about, as well as thinking about well-being, we also think quite a lot about the development of our people, thinking about allowing them actually to take a step back that says, I am in a particular place in my career. Do I want to be the very best at what I'm doing now? Do I want to be the chief exec of the organisation or the medical director? And what that means in terms of their development. And again, that's something that we're sharing across the collaborative. But you can also see that many of our staff rightly aspire to compete nationally or regionally with other teams, and you can see here the tissue viability nurses who got a high commendation in the patient safety collaboration of the year. You can see that Rajesh, our head of clinical engineering, won the team leader of the year, and Haida, our sustainability lead, actually won the Emerging Leader of the Year award. I mean, sustainability in this organisation is something that every organisation can learn from. And it's certainly something from my own other organisation, so THHFT, that we've taken the learning from here, because it's something that's absolutely at the core of how this organisation works. And that leads me to of the work we do, in the kit we use, in the way that we do our laundry, in the thinking about how we run our ambulances. It runs through the core of this organisation, and I think it's something, I don't know how many of you knew that already, but I think it's something that we should talk about a little bit more. Thank you. I want to take a minute actually to say a thank you to our community. So we are well supported by our volunteers, we are supported by our charity, we are supported actually outside of working hours by many people that sit around our community. And you can see some of the events on here with our children, often with our older patients as well, and also by Hillingdon's partnership with our ICB colleagues, with our local authority colleagues. Hillingdon is quite special in that way. It's unique in the fact that the community mental health, local authority, and the ICB work together in a very, very joined up way, in a way that we don't see everywhere actually. So that's something that, again, that we should feel very proud of. So from me, I think I would say we have improved our quality, we've improved our operational performance, we spent time thinking about how we improve the working life of our staff, and I hope Virginia will echo this, but we'll see. We're trying to do that within the resources we've got, and as you know, that is a challenge here, but it's something that we're determined to do. And we do that, and I say that with a big thank you to all of the staff here and their commitment, and a big thank you to the community. Thank you. Virginia.
Thank you, Leslie. And now we have Virginia Massaro, our Chief Finance Officer.
Hi everyone, really lovely to be here. It's my first annual members meeting at Hillingdon as well, and actually I really echo what Leslie said about the welcome I've had here. It's actually full circle for me. So I actually started my NHS finance career in Hillingdon as a graduate trainee many moons ago, and I've seen had a very warm welcome back to the finance team. Some of them have been here 20 odd years since I was first here, so it was really lovely to see some familiar faces as well. So I'm going to do a bit of the statutory part of our annual members meeting, so please bear with me as I go through a few facts and figures around the annual report and accounts. So firstly, what is the annual report? It is a legal document every NHS trust is required to produce. It's a comprehensive report of the trust activities over the previous year. So for this one, we're talking about 24-25. It covers our quality, performance, workforce and finance, and the annual accounts and parts of the annual report are subject to external audit, which was completed back in June by our external auditors, ASETS, who provided an unqualified opinion on our accounts. Our accounts and annual report are laid before Parliament. That was done earlier this week, and are available on our website. So if anyone wants to go and read them, they are there and published on our Hillingdon website. If I just talk through some of the financials. As Leslie's sort of alluded to, we haven't had the strongest history of financial performance at Hillingdon Hospital, and last year was a little bit of a decline. So I will talk through that very briefly. So our overall position, we reported, the light blue bit is our actual reported position, and the dark blue bit is an adjusted position. The dark blue bit is the bit that we're held to against. We did report a 34.6 million deficit in 24-25 at Hillingdon. That is primarily due to a one-off item relating to an impairment of one of our buildings. So we had a one-off hit last year, which was £31.5 million. That is the biggest part of that. We did also miss some of our cost improvement targets, so our savings targets in the year, which also led to our deficit last year. We did, however, in the last few months, hit our forecast position, and we were in line with our, if you ignore the impairment, we were in line with our forecast. And we did really start to see some really good financial control in the second half of the year and going into this financial year. In terms of our turnover, so we have continued to grow in size. So we ended the year as 400 million turnover, which is the green line there. You can see increasing from previous years. So turnover is our overall income that we receive as an organisation. And then you can see the dark black line is our cash position. So we did see a drop in cash, and that is primarily as a result of some of the brought forward deficits that we've seen. It is a lot more stable this year, so we're looking forward into this year for hopefully a period of much more financial sustainability. In terms of our overall position, I've talked through this already, but these are our accounts, a summary of our income and expenditure accounts. I won't go through it all, don't worry, but the reports the overall position of 34.8 million deficit last year, and then the adjusted position of 34.6 million, which we are held against. Some of the things we've reinvested back into, so we did spend £24.6 million in 24-25, reinvesting back into our capital programme. So that covers our estate, our equipment and our digital and IT, some of which Leslie's alluded to. Single biggest programme was the new hospital programme, and Jason and Al are going to speak a little bit more about that programme. And then you can see there we spent some money, quite a bit of money on estates works, repairing and replacing some of the urgent work here, so fire replacement and improvements, and infrastructure improvements. And then some work replacing medical equipment and digital. And I think the important thing for me is making sure that we have the financial sustainability so that we can continue to reinvest back into the organisation. That's it from me. I'm going to hand over to Ian.
Thank you. Thank you very much, Virginia. And I'd like to welcome Ian Bendall, our lead governor, to the stage.
Oh, there. Stolen. There we are. Excuse me one moment while I just get my script. Yes, I'm Ian Bendall. I'm the lead governor, and I'm very pleased to be able to address you this evening. I'll first of all say I'm ably assisted by Jan, who's sitting at the back there, the Deputy Lead Governor. If I could just press this little button and get the first thing up. So, of interest to everybody, I guess, is what does the Council of Governors do? We appoint, I liaise with the National Health England when direct contact with the chair is inappropriate. I work closely with the Chair in Common and Vice Chair, and I do. They're very, very open to any approaches that I make and give me a lot of information, so that's an excellent thing from a governor's perspective, that there is a good liaison between the executive and the chair and the NEDs and the, non-executive directors and the Board of Governors, and that works, I think, very, very well. As a foundation trust, we are accountable to our local communities, patients and staff. I think you all know that, and what we do is the members have the right to become governors, and I would certainly ask you, all the members, to think about putting their names up to be governors when the time is appropriate, when the elections are due. From a personal note, I've been now governor for 12 years. I've got just over another year to go before I get thrown out. I must say I've enjoyed it thoroughly. It's been an extremely broadening experience in many ways, not just my girth, but yeah, it's an interesting job, and it hopefully helps the community in trying to understand and guide what the hospital does on behalf of the community. So that is an excellent thing to be involved with, and I would recommend it. The two main responsibilities for governors are the individually and collectively to hold the account the non-executive directors, and we have some of those people here this evening, I'm pleased to say. And what that means is that when decisions are made or about to be made or talked about in meetings and so on, it is our job to ask, is it appropriate? Does it benefit the patients? And we use at that time to have a conversation which says that, have you thought about all these things? It's not our job to run the hospital, but it's certainly our job to say, what did you think about these things that we've thought of, and to get replies and so on. So that works extremely well, I certainly believe anyway. I talked about that, got it out of order. Membership engagement. We also represent the interest of the members and of the public, and to be held to account by them. So if there are members here tonight, I'm sure there are, it's your role to hold us to account and say, have you spoken to the NEDs about this or that, or whatever it happens to be? And we would welcome that opportunity to raise those concerns with the various NEDs and the chair of this hospital, and indeed the group chair, should it be necessary. One of the things that's worth remembering more clearly is, backwards. One of the things that's worth remembering more clearly is that what we're not responsible for. We're not responsible for the day-to-day running of the trust. That's up to the executive to do that, and they make decisions based on good business decisions, based on the things that they know, also the things that they are, if you like, for want of a better word, forced to do by whatever the government in power is at the time in terms of regulations and so on. So that is not what we do. We also don't handle individual complaints. We handle complaints of a nature which are generic. So if you pick up from somebody, that their auntie has had bad treatment in the hospital, then you wouldn't just disassociate yourself with it. But what you would do is you would try and find out if that's a generic thing or if it's a one-off. If it's a one-off, then there's the PALS process to deal with that sort of query. And we have no veto over board decisions, obviously. It's the board who are responsible legally as well as morally to make those decisions and in the way that they think best for the patients. And it's our job, as I said, to hold them to account. And the phrase that we use for that, to hold to account, is, can you assure me that? So whatever it happens to be, we seek assurance from the NEDs that the appropriate decisions have been made. Okay, we have more than 5,842 public members and 3,378 staff members. One thing I I forgot to mention earlier on was that most of the governors are geographically related to the borough in terms of north, central and south. But we also have staff governors who represent the groups of skills within the hospital, surgeons and doctors and nursing and dental and physiotherapists and so on. They represent those. So there is an overall cover within the governor's role. Governors are encouraged to contribute into the community and thereby pick up things that they perhaps wouldn't otherwise. I mean, for instance, I liaise with our local residents association. I live in Harefield, just down the road, and I liaise with the residents association there. I also, more importantly, pick up a lot of stuff at the cricket club. So I usually manage to get my ear bent at when I go for a pint at the cricket club or into the King's Arms, and then I take that into account and look at it and see whether there's anything to be done about it or not, as the case may be. The governors and the members are encouraged to sign up to be governors, as I said earlier. It's quite hard to describe to people why you do it. It's not anything we get paid for. It's a voluntary thing for governors to do it. And as I say, I've been doing it for 12 years now, and it's not a power thing either. It's a thing that says I can be in a position where I may be able to assist the population with regard to the business with the hospital. Now we come on to probably the elections for the governors. They are held variously. We have some roles of 1 year, 2 year, and 3 years. So there's a staggered sort of uptake of governors. So we don't all go on one day and then all come on one day. And there's always a degree of overlap, so that there is some degree of expertise within the governor community. The following appointments we've been involved in are to appoint Vinita and as a non-executive director, to appoint Carolyn Downs, who's our hospital, the Hillingdon Hospital chair, who's responsible for the NEDs. To extend the appointment of Linda Burke, who's one of our NEDs, and Simon Morris, another one of our NEDs, for 1 year extensions. And to appoint Mike O'Donnell as the non-executive director of the board. So we get involved in both the appointments and also the setting of the remuneration. So it's quite an important role in that respect, that there is some degree of public concern about who is being appointed and what they're getting in their back pocket for doing their very valuable job. Okay. On a personal note, again, I'd like to just say that I personally have a very reasonable relationship with all of the executive. I'm able to go and talk to them. And they talk to me, which is not bad. Which is quite nice. And with Leslie and with Matthew and so on, and Sarah, and all the people that are involved in both the executive and those very close to the executive. Altogether a pretty reasonable role to be challenged with. That's it. Any questions? Are we doing questions? Oh, okay. Thank you.
Thanks, Ryan. That's great. And so I am very excited now that we're going to take your stuff with you. Very good. It's very pleased to be able to do the first of the three presentations, and hopefully, I have my fingers crossed, we have Alistair Slessor, who is a consultant colorectal cancer surgeon, join us. Look at that. It's fantastic. And Alice is going to talk to us a bit about breast surgery breakthrough. So welcome to the annual members meeting, Alistair, and it's all yours.
Hello. Unfortunately, Ms. Slessor wasn't able to join us today. My name is Vladimir. I'm Senior Registrar of Mr. Slessor, and I'm pleased to speak on his behalf today. Do you hear me?
Yeah, thanks. Yes, we can hear you well. Thank you very much for joining us, Vladimir.
Yeah, so I'm incredibly proud to share that Hillingdon Hospital and Royal Free Hospital became the first in the UK to deliver a new advanced microsurgical breast reconstruction technique. And I had the privilege of being directly involved on a couple of these cases. And it's a true example of what collaborative patient-centered innovation can achieve. And since then, since the first case, 2 more cases has been successfully completed, and we're committed to developing this service further. And it's important to know that this is just one part of exciting surgical landscape we're part of here in Hillingdon. From complex abdominal wall reconstructions and robotic hernia repairs. It's important to know that recently we did a high intensity list and we did 8 robotic hernia repairs in 1 day. 7. Yeah. To advanced, and also we're doing advanced oncological procedures as well. So it's a dynamic, forward-thinking environment, and I feel fortunate to be part of it. So thank you again. Ms. Slessor wasn't able to join us today. He's very busy, but he's sending his apologies. But I was pleased to speak on his behalf.
Thank you very much, Vladimir. It's really great to see genuinely leading edge work going on at Hillingdon Hospital, and the benefits coming out of the robot that we invested in as well. So good news. Thank you so much for your time, and keep up the good work. Thank you.
Thank you very much.
Very good. And I hope we are going to be joined by Dr. Alison Wood. Is that Alison? Yes, it is. Excellent. Welcome, Dr. Wood. And Alison's who is a consultant in elderly medicine and internal medicine, and is going to talk to us about virtual ward work. So, Alison, it's all yours.
Thank you. Thanks for having me here to talk today. I'm joining you from Hillingdon in my office. I've been clinical today, so apologies I couldn't be there. So I'm a consultant in elderly care medicine, and I'm also the lead clinician for virtual wards at Hillingdon Hospital. And I'll be joined today by my colleague Anthea Manuel, who's a senior sister on the paediatric virtual wards, otherwise known as PATCH. We want to speak to you today about the excellent work taking place in the virtual ward programme at Hillingdon. Virtual wards are a concept which grew out of the necessary shift to virtual and remote care during the pandemic. And Hillingdon Hospital's respiratory team responded with the rapid establishment of a COVID virtual ward in 2020, which helped patients avoid hospital admission and allowed safe delivery of care to vulnerable patients in their own homes. Since then, there's been a significant scaling up of virtual wards in Hillingdon. We now have an 84-bed capacity virtual ward programme, which covers 5 different specialties. Our virtual ward teams look after patients with heart failure, atrial fibrillation, diabetes and chronic respiratory conditions. We also offer general acute medical wards and general paediatric virtual wards. These virtual wards offer an alternative to inpatient care for unwell patients who would otherwise be admitted to the hospital. Patients are looked after in their own homes and provided with remote monitoring kit, which allows a monitoring hub to track clinical parameters. The patients are contacted by clinicians daily, and the care is overseen by our specialty consultants here in the Trust. The benefits are huge. These pathways ease pressure on our busy emergency care pathways. They also offer an often much preferable alternative to hospital admission for patients. Patient feedback is consistently excellent. Who wouldn't want to be looked after in the comfort of their own home when possible? We're very proud of the virtual ward programme in Hillingdon. I'm going to hand over now to my colleague Anthea to describe the journey of a young patient recently looked after by our paediatric virtual ward team.
Thank you, Alison, and good evening all. As Alison mentioned, we are the paediatric part of the virtual wards service based at Hillingdon Hospital, and we deliver a hybrid model of care through a combination of home visits, telephone reviews, and video consultations. PATCH stands for Providing Assessment and Treatment to Children at Home. We aim to improve patient flow and experience by facilitating the early discharge of children from both accident and emergency and inpatient wards, recognizing that those with mild to moderate acute illnesses are often best cared for in the comfort and familiarity of their home. We deliver care for a range of conditions, including respiratory illnesses, gastroenteritis, fever and jaundice using interventions such as respiratory assessments, fluid management, IV antibiotics and home phototherapy, just to name a few. The patch team comprises of 5 experienced senior nurses who all thoroughly enjoy their job and are proud of what they do. But we recognise that the patch role requires a distinct and advanced skill set. To ensure safe, high-quality care and to support the delivery of evolving pathways through both Hillingdon and primary care routes, we are actively upskilling our Band 7 nurses in advanced clinical and diagnostic capabilities to equip our nursing team with enhanced skills to meet these and future requirements as part of the 10-year health plan for England. The patch model has been adopted across North West London with teams based at St Mary's, Chelsea and Westminster, Northwick Park and West Middlesex hospitals, with the Ealing area uncovered. Discussions are underway to address this, as it is a patch aspiration that all children across North West London will have equitable access to a patch service. Patch continues to grow rapidly, embracing new initiatives with enthusiasm and agility. Our most recent development is the creation of the Hillingdon Patch Voices Forum, a focus group designed to allow patient, carers and young people to share feedback on their hospital experience. This initiative was piloted in March 2025, with feedback largely centred on practical improvements such as clearer signage on the paediatric department, a better understanding of what to expect on arrival, and extended patch service hours. The next forum is planned for autumn 2025, and I have one of our first members with us, Rebecca, whose baby Drew was cared for by Patch over Christmas 2024. Hi, Rebecca. I hope you and your family are well, and I just wanted to ask you to just share with us what aspects of the hospital at home service you most appreciated.
Hi everyone, hope you can hear me okay over Teams. So when the patch team came for our home visit, I feel they really gave me the reassurance and confidence to continue managing my baby's symptoms at home, which meant we avoided readmission to hospital. I think having our own home comforts in an environment that we were familiar with, surrounded by our own support system of myself, my partner, grandparents, siblings if needed, it really reduced my stress and anxiety as a mum and just allowed me to focus on caring for my baby. And in turn, I believe this positively impacted her recovery. We were under the hospital at home team from around the 23rd to the 26th of December. So quite a stressful time for any family. And it just meant that we could still make Christmas as normal as possible for older siblings. And although she was very poorly, we still found some joy in our baby's first Christmas. So yeah, very positive experience from the patch team from us.
I think you won people's hearts there. There's people going, ah, in the room.
The star of the show.
The star of the show, yeah. Thank you very much indeed.
You're welcome.
Well, thank you so much for that presentation. I think it's that's how I feel every day at work. It is fantastic to hear the way in which technology has been made very human in terms of supporting, be it elderly people at home or mums and their babies, being able to stay in their own homes and with their family. And so thank you so much for everything you've done there. And this is brilliant news. So thank you and enjoy the rest of your evening.
Thank you.
Well, I thought that was brilliant. So that's and from brilliant, we move to Jason. Come down. Jason C, so the leader of our redevelopment programme.
Good evening, everybody. So, building our new Hillingdon Hospital. So there's been a few years in a row where we've talked about it here. But the marvellous thing is, and it's testament again to everybody in the room and their support of, because it's our new Hillingdon Hospital, I think that is what's given us the momentum to get to where we are. So yes, there is a hospital, but if you look at the work Alan and Keith are doing, so Alan leading on, well, the new models of care from a hospital perspective, and Keith from a place level perspective, So how we're working with all our local partners, so the GPs, the Community and Mental Health Trust, the university, the local authority. The key piece that everybody has got confidence in is if you look at what they're driving in terms of the new model of care, that allows us to build a new hospital. So it's absolutely brilliant in terms of the momentum we're getting. And the key piece about that partnership, we're working very closely with our colleagues at the New Hospitals Programme. So that's our colleagues at the Department of Health and Social Care and NHS England. So what do we want to do today? So the plan for today is just to give you a little bit of an update on the government's announcement of the New Hospital Programme, the next steps for the redevelopment, and then I think we've got general questions at the end. So if you haven't all sort of spoken to me already, we can take more questions at the end. Just recapping on previous years. So probably on previous years, I've used terminology such as pathfinder, cohorts. Now we've had a new government and we've had a government review. We are now in the business of waves. So if you look at what the Labour government, in terms of their review of the New Hospitals Programme last year, that original 40 hospitals that was in the Health Infrastructure Plan have now been allocated into 3 waves. So you've got the wave 1, construction 25 to 2030, then wave 2, 5 years on, wave 3, 5 years after that. Wave 1 is quite an exclusive club. If you look nationally, there's something called the RAC hospitals, which is the aerated concrete. So you've got the 7 RAC hospitals, you've got Milton Keynes, you've got Manchester, and if anybody watched when he announced in Parliament, this is where I was feeling slightly unnerving when the Secretary of State made his announcement, big pause, and then he went, and Hillingdon, and he named it last. So that is wave 1. So well done to everybody in the room and your ongoing support, because that has made us absolutely up there in the front of the pack. So now there is just the small matter of we've got to crack on at pace and deliver the new hospital. So confirmation of wave 1 in January. We are now gearing up on the design refresh. So you've got something called the Royal Institute of British Architects, so something that's referred to as RIBA. You've got RIBA stages that you go through. We've got to crack on now at pace with our clinicians, working with the New Hospitals Programme, because there's what we're working to now is a standardised design, getting that all worked through. 3 business cases in the process, so we've already got a strategic outline case approved. We're stage 2, then refreshing our outline business case, and that will be ready next year. We then have the full business case in 2028. We're looking then for construction to start summer 28 and being open to patients very early in 2033, maybe if the team aren't watching, hopefully in 2032 as we really push the agenda. So a huge amount to do, but we're very confident of our delivery. This is like a game show piece here. This is what your hospital could look like. But the brilliant thing is here, if you look at the work of the team and what we've all been doing in partnership, the new way of building hospitals will be something called Hospital 2.0 with this standardised design. At a very simple level, it's like a Lego set about how you'll put together the standard parts of a hospital. We were really fortunate in that previously there's been 2 reference sites in England. One was a low-rise reference site and one was a high-rise reference site. And this high-rise reference site is some of the early designs. Probably wasn't very sort of cryptically referenced. This is Project H that we did nationally. So that's what the new Hillingdon Hospital, as we evolve that design process, we've pretty much worked out some of the massing and stacking already. And that's me finished. So, as ever, a huge thank you to everybody in the audience because you've been fantastic in terms of your support. I'll hand it back to the chair.
Thank you, Jason. And we've got a few minutes to take a few questions, if anybody has any. We're going to have magic. We're going to have hands up here, and I will take your question first. And then questions that come in on the chat are going to get transcribed onto this big screen that's in front of me. But please, your question first.
Thank you. I know a lot of work has been done in the hospital for inpatients, and a lot of progress has been made recently. However, one of the areas of concern for me is the amount of time outpatients are waiting to be seen. 5, 6, 8 months. And I'm sorry, as hard as everybody's working, that I don't find acceptable. So is there something being done to improve this, please?
Thank you. I'm going to...
Shall I go first?
Go
And
on,
then
you go first.
Alan will probably correct me, actually.
They'll turn that on for you, Alan, when you get to speak.
Thank you. So you're right. You're absolutely right. And we are working, actually, not just this hospital, but all of our hospitals to address it. So you're right that more patients are waiting to be seen first, so the first outpatient appointment. So a few things that we're doing. We're having a look at the job plans of all of our consultants to make sure they're focused on the highest areas of need. We're having a look at the templates in outpatients and actually in theatres to say, are we being as efficient and productive in terms of the numbers we're seeing, in terms of thinking about the percentage of patients who don't turn up for their appointments and making sure we fill those. And actually we're having a discussion, we've had a discussion with the consultant body, there's some of them in here tonight, that says, how do we convert some of those follow-ups to new patients so that we get them seen more quickly. Alan, and indeed some of our consultants might want to say something, but Alan, you might want to say something.
Yeah, thank you very much, Leslie. That's exactly right. We are dissatisfied as well, but of course we're not receiving the care. To assure you that it's having an effect, we have a meeting every month with NHS London about exactly that. We've set a trajectory about how often we'll see patients and how quickly we'll see them. We're above trajectory already. We have to nationally see 60% of patients before 18 weeks, which again is a long wait, but that's the government target. We're already a hair's breadth away from achieving that, and our trajectory is to go a lot further. So as Leslie says, we want to make sure that we only see patients that need to. If we can follow people up by telephone or by asking the patients to just alert us when they're not well, or whether the GPs can follow them up, we're implementing those things so that people who haven't been seen get seen, because that's where the peace of mind occurs. Thank you. So we have to reach that by the end of the financial year, so that's March 26, but I think we'll make it in the next couple of months.
Yeah, and we're not in any doubts. I mean, if you were to go back to 2010, that was, I think, was it 80 or was it 90% within 18 weeks? Yes, so the NHS as a whole is a long way away, and the 60% is as part of us working our way back. Did you want to add something on this, Jan, or can I? So into the microphone, otherwise the people in the big wide world.
Hi, Leslie mentioned about people not turning up for appointments, and we've talked previously around different methods of communicating appointments. So given that the population is majority non-English speaking in Hillingdon, how are you addressing that? People who are visually impaired, people who are deaf, people who don't use technology, all of those things. So what's the next step to make sure people know about their appointments?
Yeah, it's a really,
So that if you're facing that direction, you'll be picked up on the camera as well.
Okay. Yeah, really good question, and something that is really close to my heart, and in making sure that that people know that their outpatient is coming up. And actually, what we've got is a group of volunteers that are actually ringing patients a few days before to remind them that their appointment is coming up. And we've got a range of volunteers who speak a variety of different languages, and that they're able to then converse in the language that's comfortable for the person that on the end of the telephone. And actually, we've had some really positive feedback as they've been able to iron out any other issues that they might be concerned about before they come for their appointment, whether that's be where they go to park, how far away is the distance of the reception to where the outpatient is, will there be somebody there to help aid me to get to where I need to get to. So we've seen some really positive results from that. Thank you.
Thank you. I'm going to take one from the chat now, which was a question which, Leslie, you probably want to pick up, which is, what assurances can we give that the closure of the minor injury service here will improve services for people of North Hillingdon?
Again, I'll start, and Alan might want to come in. So thank you. I mean, I'm just going to put a little bit of context around this for everyone, which is, of course, as we've done the presentation tonight, we've reflected on, the job ahead of us, and although we've made progress in all of the areas we've spoken about, there remains concerns in how we see patients in our emergency department and how long they have to wait, particularly our sickest patients. And we've reflected on, actually, how do we get our new hospital built by ensuring that we've got a sustainable and resilient financial environment in which we're working. So in terms of when you balance those things, you start to look at all the services that you offer, and you start to think about which of those are absolutely essential and which of those are very nice to have, but actually we could provide them in a different way. And when we start to talk about the minor injury unit, that's one of the areas where we started to look at the use of our resources, so our very special resources, which are very well qualified staff. Is that the very best use of that resource? And to keep that unit going, it is an expensive unit to run as well. And it definitely is a very well-run unit. But comparatively, when you look at the numbers of patients that are seen there, and indeed what those patients are treated with, you have to say, could we use that resource better to see our sicker patients? That's what we've done. So sorry, that is a context, because not everybody here will understand what we're talking about. So what our recommendation, our plan is to say, actually, we're going to re-provide that service on the Hillingdon site, so that we can ensure that expertise, that resource is used to treat the patients that we need to treat and who are waiting a very long time. And indeed, we clearly can answer the telephone there, we can do all of those sorts of things. And many of the patients that are seen in the minor injuries unit or the nurse-led unit actually could be seen in general practice, could be seen by community services. And a proportion of them, of course, don't actually come from Hillingdon, they come from across the border in Hertfordshire. So this is a bit of a long-winded answer, and it's a long-winded answer because I do know that for some people, this hurts, thinking that you might not have something. But when you have to look at the overall provision, sometimes you have to do some things that are tricky and difficult and challenging. And that's where our thinking came from with this. So that service, patients from the whole breadth of Hillingdon can access services. Those services will need to be accessed in a different way. Alan, you might want to add to that.
Yeah, I just realised I didn't introduce myself before. My name is Alan McGlennon. I'm the Chief Medical Officer. So yes, there's really good context from Leslie there. I think the question was, how do you provide assurance that things are going to get better? We've already heard that the CQC realise that we're on an improvement journey. but they still think there's areas of improvement in our urgent and emergency care pathway. We also know that our performance, although we've improved it over the last 3 months, we've got to make sure it's sustained. And how quickly you see patients who are acutely unwell and how quickly you move them on to definitive treatment really does affect their long-term outcome and whether they live or die. So the reason that we're taking a long time to look at this is those two things are really important. Third thing that's important also is we've not been living within our means over the last number of years. You saw that graph. So what we've done is we've looked at all of our services and how we deploy our most precious resources and asked ourselves and asked our patients and asked our staff and looked at the stats behind it to say, have we deployed our people in the right places? And we felt that we didn't. And that's why we're going to concentrate our staff at the Hillingdon site. And what that will mean is we will rely a lot less on temporary staff who are more expensive, who don't always know our systems, who don't always know each other as well. So that is the assurance that we will get a better service to the patients of Hillingdon. We are not under any illusions that that means more travel for some people, particularly north of the borough. We're very aware of that. If we lived in a different universe, we might not make this decision. But to make sure that our patients are safe and we use the taxpayers' money wisely, that's a decision that we've come to.
Thanks very much. Thank you. I'm going to take a couple more questions before I wrap it up, because so there's a question here about can we put more posters up about the fact that we have voluntary governors, so that that patients and the community can know. We are doing some work around digital screens to communicate that, but there's no reason why we shouldn't put some actual physical posters up as well. So we will look at that. I've got, and I think these. So the first one I think is going to land with Alan, which is. Can we be assured that improvements in earlier diagnosis of dementia will be on the hospital's priority list? Do you want to say something about that? And then I've got another question about diversity in the community, which I'm going to ask somebody to pick up as well.
Yeah, so on that particular question about neurology, yeah, you can have assurance. We've got a very active neurology department. We've got one of our new consultants who's very much looking at some of the earlier biochemical markers of various forms of dementia. So what we aim to be is a hospital that not only does research, but also brings in innovation as early as possible. So he will be doing that, and you'll be hearing more about that this year. Thank you.
Thank you. And the last one, which I think was linked a little to what Sarah said, which was just noting that Hillingdon Borough is very diverse, and is there more work that we could be doing to cater for the needs of that diverse community in the hospital? Do you want to say something?
Yeah, short answer to that is yes. There are certain areas in our hospital that really understand our population well. Paediatrics would be a great example. You know, they work in the community, they have constant contacts in the community, they speak with the GPs constantly. We are trying to marry up the 10-year plan that you've been reading about with the plans that the Hillingdon Care Partners that Keith represents has brought forward. That's a lot about integrated care, making sure that you understand your population, because the needs down in Harlington are different than those in Moore Park, and we can agree on that. But for that to provide different care, we've got to understand the needs and have the ability to deploy things differently. I think a lot of this comes working well together, but the knowledge of what the patient needs sits an awful lot with the GPs and with the doctors as well. So our inclination is to make sure that all of our different services are population focused first, and where they need to make any changes, that's when our relationship with THHFT comes in.
Thanks, Alan. I'm going to take one last question in the room, because I'm already a quarter of an hour over, and then we've got some questions. There are a couple of questions I haven't picked up in the chat, which we will answer in writing. So please, sir.
Due to the inefficiency of some of the doctors' surgeries, I think a lot of patients are just referring themselves to A&E, which is causing an influx, which is really they're not able to deal with. I understand that it's going to be a referral to maybe 3 off-site places where patients can go who are not being dealt with from their local surgery. Can anybody explain in detail or little detail what this is?
Go on then, Leslie.
Yeah, I was going to start to say, so look, I'm usually very hard on GPs. I think that's a little bit harsh because actually the data tells us that they're actually seeing more patients now. So you're right, we need to improve primary care. I think Keith's going to tell us about how we're going to do it.
Introduce yourself, Keith.
Good evening, colleagues. My name is Keith Spencer. I'm the Managing Director of Hillingdon Health and Care Partners, and my job is to integrate care and coordinate the work of the health and care organisations across Hillingdon. So I think, colleague, what you're referring to, the model that Jason has referred to in the new hospital is built around delivering more care closer to home. And if you've read the 10-year plan, you'll have heard about neighbourhoods and neighbourhood centres. We're actually ahead of the game. In Hillingdon. I'm sure Ian will say we did a presentation to our Council of Governors earlier this year. So there will be 3 neighbourhoods. There are 3 neighbourhoods in the north, which covers the area we're in the west and in the east. And at the heart of those 3 neighbourhoods will be 3 hubs, 3 neighbourhood hubs, 3 neighbourhood centres, which will offer a much wider range of services that actually, historically, you would have gone to the hospital for. So there'll be more GP appointments. There'll be more access to mental health. You do not have a mental health hub in the north of Hillingdon. Your mental health services are delivered from the south. So we'll bring a mental health hub north here. We'll provide a range of diagnostics, X-ray, ultrasound, which you currently have to go to the hospital for. So they will be built around general practice, but they'll be called neighbourhood hubs and through integrated neighbourhood teams. And that's part of the government's new plan. But we've been working at this now for nearly 2 years, and we're about to implement them.
Thanks very much. One last hand went up just as I shut the gate, and you've made the trouble of being here. I'd like to take your question. Thank
you. When the young lady, Virginia, well, compared to a number of us, you're young. You had your charts. You had various spends on, had several million on various things. It struck me that the medical equipment spend was not really that much. I mean, the cost of equipment is, you know, these things cost a lot of money, and it was only 3.1 million.
Yeah, thank you. Thanks for the question. So, and thanks for calling me young. So the spend for medical equipment is it's a really untechnical term, but quite lumpy. So when we have to buy a big bit of equipment, so such as an MRI scanner or a new CT scanner, we would have quite a high spend, and then it goes down in the in-between years. So it does vary quite a bit, and that happens to be how much was spent last year. So yeah, that's the reason why it's relatively low, is when we have to buy big bits of equipment, it increases.
Great, thank you very much. I'm going to wrap up our annual members meeting there, but I would just like to say a few thank yous. Firstly, thank you to our presenters who've come here and told their stories. I'd like to extend my thanks to the Council of Governors, and particularly to Ian as our lead governor, for their hard work during the year and showing up of the evenings here and at Hillingdon Hospital and online, and keeping the non-executives on their toes. I'd like to thank the non-executives. We've got Nick and Vanita in the room, and we've got Carolyn, Pat, Simon, Linda, Mike and Baljet have all joined us online for their unstinting efforts and putting up with me as their chair. And I'd like to thank the leadership team, Leslie, Alan, Sarah, Virginia, Jason, and the others who are in the room for their hard work during the year. Hillingdon, I think, is a hospital that's on the up. Things are improving and continue to improve. We have an exciting future as laid out by Jason, but we want it to be an exciting near future as well as an exciting far future. And I think I should finish by extending my staff, my thanks most importantly to the staff who work through the challenges, through the facilities, through the growing demand, and continue to try to deliver excellent care every day. So thank you for coming, and thank you for the people for the work they're doing. So, cheers.